Hi, everybody, and welcome back to EMS Training. This week, we're going to be talking about trauma, specifically amputations, burns, avulsed teeth, and chest trauma. So let's just jump right in.
So in cases of amputations, you're immediately going to refer to the protocols, and that includes ABCs and vital signs. And then with the stump, you're going to elevate and wrap, and the wrap is going to be a moist, sterile dressing covered with a dry bandage. So another point to take care of is when you're taking care of the amputated part, you're going to wrap that in a moist, sterile dressing with sterile saline solution and place it in a watertight container like plastic bag, and make sure you have ice so that you can preserve it without freezing it is the big thing. And then you're going to transport the patient with the part.
Here's a nice little illustration. We've got an amputated arm here, and then you're going to take some saline solution and soak a sterile dressing, wrap it around that arm, put that arm in a plastic bag, and then put that bag on some ice. Make sure not to freeze it. So next, we're going to be talking about tooth avulsion. So you come onto the scene, and there is a patient with a missing tooth. So first, you're going to want to locate that tooth and pick it up by the crown. You don't want to touch the root of the tooth because you might damage it. Next, once you're holding that tooth by the crown, you're going to want to rinse it off and don't remove any tissue that may be stuck to the tooth. Then you're going to want to remove the clot from the socket, suction the clot if needed. And then once you've got that socket cleaned out, you're going to put the tooth back inside and hold it with your fingers. Once that tooth is in there, you're going to put some gauze over top of the tooth and ask the patient to bite down on that gauze. Then immediately report to the hospital staff that a tooth has been reimplanted. The best transport medium for a tooth is the socket. So if you can put that tooth back in the socket, do it. And the best chance for success for a reimplantation is 5 minutes after the injury. So you have to do this really quickly. Contraindications for a reimplantation include altered mental status, if the patient must be transported in a supine position, if the gum or the bone are missing or broken, or if the root is fractured, or if the patient is having cardiac issues or is immunosuppressed, they may reject the tooth. If the patient is not a candidate for reimplantation, take that tooth and put it in some milk or the patient's saliva or saline and keep it cool.
Okay, so in the next case would be burns. Number one thing you're going to do is stop the burning. So that will be ABCs, vital signs, airway management, and oxygen therapy if needed. And then make sure you're removing the smoldering clothing that's not adhering to the skin. That includes jewelry like rings and bracelets. Anything distal to the burned area has to go if it can. You're going to cover the burn with dry, sterile dressings. And the eyes are going to require a little bit more care. You're going to use copious irrigation, so saline, tap water if you need it. Burns should be covered with dry, sterile dressings, especially if it's more than 10% body surface area. But moist, sterile dressings can be used only if the burn is less than 10% body surface area. So again, when you come on scene, of course, assure scene safety and be aware of things like hazmat. So liquid chemical burns are going to be different. You're going to flush that with copious amounts of water, saline, anything you can get your hands on for 20 minutes. And dry powder burns are going to be a little different. You're going to brush the powder off first and then use caution to avoid the spread of the contaminant. Consider other injuries like cardiac dysrhythmias, and when you're looking at what the patient has gone through, consider things like smoke inhalation. That's going to warrant things like administration of high flow oxygen. Oxygen saturation readings may also be falsely elevated, so be aware of that. Be aware of hazardous material and definitely notify the destination hospital if that's an issue, because they need to get on the decontamination process. A good way to determine body surface area is the palm rule. The patient's hand is about 1% BCA. And when considering the total area of a burn, do not count first-degree burns. So burns less than 10% are only to be addressed with dry, simple, sterile dressings. And when you have significant burns, hypothermia is going to be a significant problem. Definitely use the appropriate trauma center and consider direct transport to a burn center, because sometimes they can handle situations a lot better than a typical hospital.
So the rule of nines is a good way to calculate body surface area, or BSA. Like Amaranda mentioned earlier, you can also use the rule of palms. So the patient's hand is about 1% of the body surface area. And the rule of nines is another way to calculate this. The back of the arm, for example, is 4.5% body surface area, whereas the front of the arm is also 4.5%, making the entire arm 9% of the body surface area. The back of the leg is 9%, and the front of the leg is 9%, making the entire leg 18% of the body surface area, and so on and so forth. You can do the math by just adding these numbers to figure out the body surface area. And the types of burns. So there are 3 types of burns. You've got your first, second, and third degree burns. First degree is just like when you're little and your mom tells you don't put your hand on the stove, but you do it anyway, and you burn your hand. And it's just a superficial burn that only affects the skin surface. Second degree burns are these burns with blisters, so like maybe sun poisoning. These burns affect the outermost and second skin layer. Third degree burns are the most severe kind of burns. They have killed the skin all the way down to the fatty tissue, and especially with these third degree burn patients, they may experience hypothermia. So chest trauma. Chest trauma can look like gunshot wounds or really any kind of wound to the chest. If you're coming on scene to some chest trauma, you want to make sure that the scene is safe before you actually treat the patient, especially if it is a gunshot wound. First, you're going to want to check your ABCs and vital signs, like always. And then you're going to want to also check for an entry wound and an exit wound, because if there are 2, you're going to have to treat both of them. And also check for any pooling of blood under the patient or around the patient. If you have a sucking chest wound, you're going to want to cover it with an occlusive dressing. And if they're having trouble breathing or if it increases, then you're going to want to remove that dressing while they are exhaling, and then contact the hospital as soon as possible. So this is what a sucking chest wound may look like. It's when the patient inhales and air passes through that wound. And we're going to look at the anatomy of a sucking chest wound as well. Here's the wound, and you can see that the air would just pass right through that pleural cavity or the lung housing. And if you have any questions, refer to your NYS protocols, or don't be afraid to contact the EMS officers, supervisor, or Mr. Sager. And that's going to wrap up our training. See you guys. Bye.
Thank you.